Hi, my name is Utkarsh Goel. I'm an internal medicine resident at Cleveland Clinic. And in this study, we tried to build a myeloma-specific score to predict toxicities of CAR T cell therapy in patients with multiple myeloma. BCMA-directed CAR T is now being increasingly utilized for the treatment of multiple myeloma, recently approved for use in earlier lines. But there are still no good myeloma-specific scores to predict the risk of CRS and ICANS after these therapies. In this study, we knew that the EASIX score, which has three routinely available laboratory parameters of LDH, creatinine, and platelet count, has been used to predict CRS and ICANS in lymphoma and CD19-directed CAR T therapy. But there were no myeloma-specific scores which were used to predict the same for patients with multiple myeloma. So in this study, we first assessed how the EASIX scores work in patients with multiple myeloma to predict the risk of CRS and ICANS in the first 30 days. And we found that all kind of variations of the EASIX score, EASIX-F, modified EASIX, and simplified EASIX do predict CRS and ICANS with comparable efficacy. In addition to that, we kind of built our own myeloma-specific score, which includes EASIX, the ECOG performance status, and high-risk cytogenetics to predict ICANS in the first 30 days after CAR T. We looked at, on the day of CAR T infusion, we looked at if the patient had high-risk cytogenetics at any point prior to CAR T, what their performance status was on the day of CAR T infusion, and then what their EASIX score was, which includes LDH, creatinine, and platelet count on the day of infusion. And then so each of these parameters gets 1 point in our score, and we found that patients who were in the low-risk group with 0 points had about maybe a 12% risk of ICANS in the first 30 days, versus the high-risk group had about as high as 50% risk of developing ICANS in the first 30 days. I think, first of all, this needs to be validated in external data sets because this was only a development study. But in the future, I feel like this can be used to stratify patients according to their risk of developing early toxicities of CAR T, and also decide in many centers about inpatient versus outpatient administration of CAR T, and what, in the high-risk subset, which patients to look out for who might be at risk of these early toxicities. I think it might be important to understand that high treatment burden, disease burden prior to CAR T, is associated with toxicities. So it is important to have good bridging treatment options, which I think would be helpful for patients to know. Bridging therapy-wise, I think it is a good usually practice to use something which the patient has not been refractory to in the prior lines. So that's what mostly happened in this study. And then an effective bridging therapy would bring down all the EASIX related numbers because it's a marker of disease burden and kind of prior treatment burden. So I think that would be helpful in, effective bridging would be helpful in reducing the risk of these toxicities.